I hope you can all see the slides. As Cha was sharing with you my short bio, I don't have to do it, but yes, my name is Theo Lippeveld, and I'm currently Senior Health Information System Advisor with Measure Evaluation. Measure Evaluation is a USAID funded project working on building highly performing and sustainable health information systems in low and middle income countries. So today I will talk to you about the development of a standardized curriculum for routine health information system. So my presentation, we will start with a background on why are routine health information systems so important for the health system building in low and middle income countries. Then I will go to our consultative meeting that we did last year on building an RHIS curriculum, definition of Rhs Core Competencies, and then the process of the development of a course, a basic course on routine health information systems. How did we do the pilot testing? And I will discuss briefly with you the next steps and the way forward. And then you will have opportunities to ask questions. I will try to limit my presentation to about half an hour so that we have some time to discuss. When I talk about health information system, I cannot do that without showing you first the health system, because basically the health system is the purpose of the health information systems. The health information systems are support pillars for the health system. So that's why I mostly show the framework that WHO is promoting on health systems, and this is the one with the 6 building blocks that you're probably very familiar with, so I'm not going to spend a lot of time on it. But as you can see, there is a service delivery as the main aspect of the health system, and then various building blocks are supporting service delivery, including human resources, commodities, financing, but most of all information, and that ultimately will then lead to health, to responsiveness and fairness in financial contributions. In the last decade, we have seen pretty good progress in knowledge and understanding of the role of health information systems in global health systems, and that was highlighted specifically around 2005-2010 with the Health Metrics Network. They brought the first conceptual framework on health information system strengthening. And while I don't have very much time to go through all this, I'll show you at least the proposed categorization of health information systems as it was promoted by the Health Metrics Network framework. So the slide you see here are the 2 main sources of information for information generation: population-based data sources on the left side and health institution-based data sources on the right side. Population-based data sources can be the census, vital events registration, population-based surveys, while health institution-based data sources are categorized mostly into individual record systems, service record systems, and administrative record systems. They are information systems that are health institution based, and by health institution we mean health facilities, hospital, primary care facilities, but also communities. And those health institution-based data sources are also called RHIS, Routine Health Information Systems, and this will be the focus of the rest of my presentation. So we will not talk further about the population-based data sources. This is about the routine health information systems. Now, what is the role and importance of this routine health information systems? As I said, they are facility-based, ideally also community-based, and in fact, they are the main source, and I would say even the only source of information for planning and management on a daily basis at district level and below. Mostly at district level and below, they have little access to representative data from surveys. They have not the possibility to organize facility-based services, etc. So the main source of information for a number of functions, like to measure coverage and quality of health interventions, for disease surveillance, for commodity security, for human resource management, for financial management. So this is of extreme importance for decision making at district level and below. But routine information systems also can report up to the national and global levels even. So particularly in this case for example, the monitoring of the Sustainable Development Goals. And they are also a main support for building of integrated management of health interventions, as it is promoted in recent years for more effective service delivery. Unfortunately, we all know that routine health information systems in many low and middle income countries, and I would say also in industrialized countries and high income countries, are not adequate to provide that kind of support that the health services system needs. And why is that? Well, for various reasons. I will not go far into categorize. I just categorize here the reasons without going in detail, but we have too many data that are collected. They are often not relevant. They are of poor quality. Information management is often centralized. No feedback to lower levels of the health system, district and service delivery levels. The systems are often very fragmented into program-oriented information systems with a lot of duplication and waste. There are not adequate resources available, infrastructure, electricity, and obviously ICT, information and communication technology, is poor and inadequate. And as a result, well, the final purpose of this information system to use information for decision making is not happening. So luckily, in recent days, RHIS came in the spotlight. The Measurement and Accountability for Health Summit that was held last year in June in Washington to examine how health information systems could play a more important role in health system monitoring, and specifically in monitoring the newly developed Sustainable Development Goals. In that summit, I saw for the first time, I would say, in my career, a global action point on strengthening routine health information system. It's action point number 4 of the summit, says to maximize effective use of the data revolution based on open standards. Sorry, I got a little based on open standards to rapidly improve health facility and community health information system, meaning RHIS, including well-functioning disease and risk surveillance systems and financial and health workforce account. So that was really a call to the world to strengthen routine health information systems. Now, how do we strengthen routine health information systems? Well, we have now basically all the evidence-based interventions to improve routine health information systems. The main issue is how we're going to implement them, but we have technical interventions to establish a set of essential indicators, to redesign the RHIS architecture, to ensure interoperability between RHIS subsystems. All these interventions are available technically. We have also organizational interventions that we can use to incentivize people for better use of information, to organize data review meetings, etc. These are just examples. And then we have a set of behavioral interventions for capacity building at all levels of the health workforce to collect, to analyze, and to use quality information. I think that one of the first priorities, and I think most of colleagues will agree with me, is the capacity building that we need to undertake of health managers and care providers to improve RHIS performance and management. And to do that, we need to have a better understanding of what is then the role and the responsibilities and the competencies we need at all levels of the health system by community workers, by care providers, by district managers, by regional managers, by national managers, by policymakers. So it was decided, WHO and Measure Evaluation together, to start a consultation where we brought together most experts in routine health information systems and in routine health information system teaching, and we called them together in a meeting in Chapel Hill last year, April 27-28. And the objective was to set up an advisory committee to plan, guide, and overview the development of a standardized RHIS curriculum. And in the meeting in Chapel Hill, we had Measure Evaluation representatives, WHO Geneva, the Health Statistics and Information System Division, EDES from Brussels, an NGO that works on health information system strengthening, Oslo University, who are the developers of the DHIS2 application that is used in many countries for RHIS management, of data management. We had representatives of the Instituto Nacional Salud Pública Mexico and the Public Health Foundation of India. So in that meeting we reviewed existing teaching and curricula of routine health information system throughout the world. We discussed and tried to define what were then the Rhs core competencies, and we planned for the development of a RHIS curriculum, and it was proposed and that we would focus not on advanced competencies, but rather on the basic competencies that should be present at all levels of the health system. And we also worked on terms of reference for the various committees that were putting together this course. Here is a quick overview of the core competencies that we came up with. 8 main categories: data collection and reporting, data management, data analysis, interpretation and communication, data use and demand, RHIS design, improvement and implementation, RHIS assessment and monitoring, RHIS governance and management, and the use of information and communication technology for RHIS. In the syllabus of the course that has now been finalized, you can find a more detailed overview of these competencies that are broken down in sub-competencies, as well as the need at various levels of the health system. So I can, in this presentation, not further go into detail of these core competencies, but I urge you to consult this syllabus that I will present later. And then the process of developing the course was planned with the development of an outline first in June-July 2015, and then the development of the modules between August and February, followed by the pilot testing, as I will later on show. And three committees or groups were put together to manage and implement this process: an advisory committee, a technical working group, and module working groups, as we call them. The advisory group, the purpose of the advisory group was planning, guidance, and validation of the process. Grossly speaking, they also convened the technical working group and would review and validate the output of that technical working group. And then also they would coordinate the inputs of the various partners. Membership of this advisory committee in the whole process has been WHO Geneva and Measure Evaluation co-chairing, WHO Seattle, the Universities of Oslo, Queensland, Brussels, South Africa, and North Carolina, United States, the Instituto Nacional de Salud Pública, Mexico, the Public Health Foundation of India, Health Information System Program, South Africa, and the Agence Européenne pour le Développement et la Santé, AIDES, in Brussels. So, and then a technical working group was constituted by the advisory committee. Membership of that technical working group was kind of the same as the advisory committee, the various organizations that were involved, but they had to really do the work of developing the core curriculum, meaning finalizing the list of competencies, mapping course material that were already existing and seeing what gaps we had, develop the outline, identify technical leads and contributors for each of the modules, and then to establish a mechanism for communication and coordination of sharing all these materials between the various experts involved. And the modules of the course were basically developed by what we call module groups. They had each also roles and responsibilities, as you can see. Each module group had a coordinator who was regularly coming together with the technical committee to report on progress. They were the ones that were developing the session plan for each module. They were also developing the materials, slide decks, lecture notes, readings, case studies, exercises. Mostly they were technical experts that were from Measure Evaluation, WHO, and partners. So what were the products of the course? First of all, a syllabus. The syllabus is kind of an executive summary of the course and is equivalent to the participant manual. It can be handed to participants when a course is organized, or it can also be handed to donors, countries that are interested in teaching the course. Then we have the Facilitators Manual, obviously to be a support for the facilitators of the course, but it also includes contextualization guidelines, because the course as it was developed is a generic course, but it is supposed that wherever the course is being taught, that the materials are contextualized so that they are more adapted to the various audiences geographically or functionally, as we will see. Other training materials were developed, PowerPoint presentations, case studies, exercises, handouts. They are also the products of this RHS course. A few words on the syllabus. Like I said, it's like a executive summary of the course. Title of the course is Routine Health Information System, a curriculum on basic concepts and practice. The course performance objective has been formulated as follows. At the end of this course, the participants will have acquired the Rhs Core Competencies as listed in the learning objective of the objectives of the course modules. The audience of the course are the workforce, the health workforce at large, we can say. But it could be policymakers, senior or district health managers, care providers, health technicians, and all kinds of students in health sciences. The course content, like I said earlier, is building upon this basic core RHS competencies among the health workforce, so that the course can improve work performance. There is a modular organization of the training materials, which will permit also to better contextualize the course or eventually delete or decrease the content of separate modules, etc. The course duration of the full course is 60 hours, which you can say is equivalent to 2 weeks of a course, but you can also spread it over a longer time if needed. The teaching methods are blended, but very much based on participatory teaching with case studies and exercises, and also using a experiential learning approach, meaning that most of the students are supposed to have already experience in working with routine health information systems. There are normally no prerequisites for this course, except that it is advised that they have taken a basic M&E course, so that some concepts are already well understood, like what is an indicator and some basic principles of monitoring and evaluation. Here are the modules. It's divided in 4 parts. The first module is the Introductory Module and explains the link between health systems and health information systems. Like I said, an essential link that should be well understood from the beginning. Then we have modules on data generation, indicators and data collection and reporting, RHIS data management standards, RHIS data quality, RHIS data analysis, RHIS data demand and use, modules 2, 3, 4, 5, and 6. And each of the modules have a certain length, 1, 2, or 3 sessions, and one session is 3 hours, so the total, as I said, is 60 hours. Then we have 2 modules on RHS management. Module 7 is on governance and management of resources, and Module 8 is on the use of information and communication technology for RHIS. As you know, this is a very fast-growing need for improving the RHS performance, the use of information and communication technology. Then we have the last 2 modules are about RHIS strengthening and reform. Module 9, RHIS Performance and Assessment, and Module 10, RHIS Design and Reform. The next step was, when all these materials were drafted, was to test the course. And that was done in New Delhi in June this year. As you can see, this is the group picture. And basically, the pilot test was done by a teaching staff made up of Measure Evaluation, 3 team members from Measure Evaluation, myself included, went to New Delhi for this course. And we worked together with the Public Health Foundation of India, and who has a number of faculty members, and were so kind to put 5 of their faculty members to participate fully in the teaching of this pilot course. The participants of the course were picked from a certain number of countries in Asia, but also we had 3 from India, 4 from Bangladesh, 2 from Nepal, and 3 from Myanmar. But we had also a participant from the University of Ghana, so that already there was some exposure of Africa to this course. Location was in Gurgaon, a suburb of New Delhi, where PHFI has impressive training facilities. And funding was ensured by USAID and CRO, who was kindly funding the travel and the remuneration of the PHFI faculty and the travel of the participants. The results of this course was that we got a tremendous amount of feedback from the teaching staff of PHFI and the participants on the technical content as well as on the methodology. And for those that are interested, a detailed report is available on this pilot test. Well, and here is how the syllabus looks in its final form. The syllabus is now printed and is also available in PDF file. So for those that are interested, just contact us. The contact emails are at the end of my presentation. Anyway, the final course was based on feedback that we got from the New Delhi pilot test, and that was then incorporated in the draft curriculum and materials. And a final version of the course was then available September 30th, although we are still working on editing and formatting before we put up the course on various websites. And formatting is ongoing by Measure Evaluation Knowledge Management team. So what are the next steps and way forward? Well, as I said, we need now to disseminate and contextualize this RHIS basic course, and contextualization guidelines are available in an appendix of the RHIS Facilitators Manual. We also plan to do translations of this course, which is currently only available in English, but in French. The Global Fund is most likely financing the French translation. PAO and INSP will work on the Spanish version, and other languages on demand. And then the main way of disseminating the course will be to organize training of trainers workshops in various regions in the coming year or years. Now there is also, this is the basic course, but there are also plans to develop other more in-depth courses and other courses linked to RHIS. So we for example, will WHO is already developing a more in-depth module on data analysis. of RHIS data. But we also intend to have a more in-depth module on information and communication technology, etc. Other courses will be developed for particular audiences. So, for example, for community-based RHIS, a special course needs to be developed because the audience is less educated than often what is assumed for the facility-based providers. We will also probably create an online course of the type MOOC, Massive Online Open course. And then we will develop a number of subsystem, RHIS subsystem courses, such as courses for LMIS, RHIS, etc. So these are all plans for the future. Now, here we are specifically talking to our colleagues in Asia. How can we disseminate this course here in Asia? Well, definitely the course will be posted on websites of WHO, Measure Evaluation, and EHIN probably in the coming months. And so teaching institutions in Asia, universities or other health sciences schools can easily access those websites and download the course, and eventually get assistance also from institutions like WHO or Measure Evaluation to start teaching that course. But also we hope to disseminate a course via the EHIN RHIS focus group. And the EHIN RHIS focus group is for the moment in being established. In fact, the strategic plan of EHIN includes capacity building in health information systems. So Measure Evaluation and PHFI together with EHIN explored the interest of EHIN members in regionalizing RHIS strengthening among its members and countries. And that happened in the general management meeting last year in Bali. So we drafted a mission, vision, objectives, and management structure for what we call the EHIN RHIS focus group. And we hope to later in March 2017 at the general management meeting of EHIN in Myanmar to have members of various Asian countries joining this focus group. And the focus group can then be used also to disseminate the course and to organize the TOTs in various parts of Asia. So next step in Asia is to organize training of trainers workshops with representatives of participating countries, contextualize the course materials for various audiences, and also eventually to introduce the course in various master degree programs. PHFI, who pilot tested the course, is already planning to introduce the RHIS course in their master degree in public health. So let me stop here and now take some of your questions. I have put here the names of 4 staff of Measure Evaluation who are always ready and available to give you further information on this RHIS curriculum. Emali Kulatilaka, Tariq Azim, Ali Mubari, and myself. So you will also be able to get the slide deck so that you have all this data available to you. Let me stop here and see if we have questions.
So Dr. Theo, thank you for that lecture and for introducing RHIS curriculum to us. Dr. Saputra is asking if there will be any link shared for the RHIS materials final version.
The question is if materials will be shared with the participants?
Yes, the final version.
Yes. Like I said, we are still finalizing the formatting of some of these materials. What will be available very soon? Well, what is already available is the syllabus, and I will make sure that the syllabus PDF is available via the email. I will send it to you, Cha, and it can be also disseminated syllabus. But the Facilitators Manual will take probably until the end of this year to finalize. And then also the training materials will need more formatting before being made available on the websites. Now, if there is an institution or a region that wants to move faster, there are definitely websites that we can give where these materials can be accessed, but in a less formatted version, if they want to contextualize them. So yes, but I would advise anybody to be patient for, let's say, 2 months, and by the end of January, the course should be up on the websites of WHO, measure evaluation, and definitely also EHIN.
All right, thank you, Dr. Theo. Also, here is a message from the Latin American and the Caribbean Network for the strengthening of HIS. They would want to connect with you for getting a contact with measure evaluation to translate and disseminate this course between their members. I will give their email address to you, Dr. Theo.
Yeah, I suppose these are the folks from Rhs. Rhs is a network on routine health information system strengthening in Latin America that is functioning already since close to 10 years now, and so yes, we are working very closely, as I had said in my introduction, with INSP Mexico and with Dr. Hernandez, and so the materials will be made, not only that, the materials have been made available to INSP so that translation in Spanish can happen. So I think that should, there should be no problem to start the translation as we have discussed last month, in fact, in Vancouver at the Health System Research Conference. We should start the translations both in Spanish and in French as soon as possible. The materials are available.
All right, here are other questions coming in, Dr. Theo. This question is from Dr. Kunaka. Dr. Kunaka is asking, is the curriculum developed in such a way that learners could take certain modules and not others?
Absolutely. In the contextualization guidelines, it is said, for example, it is probably not realistic to assume that policymakers can be called together for 2 weeks to study routine health information systems, but certain modules in the course are not as important to policymakers and can be shortened or even taken out in a, let's say, in a course that could be a 2-3 day course for maybe 4 days or a week for policymakers, and such contextualization certainly in the beginning, measure evaluation in WHO is very ready to help in making that feasible, because I think one of the reasons often that routine health information system reform is going slow and not spreading nationwide is that policymakers often don't have enough understanding of how routine systems work. So I think it's very important that they can be exposed to a more system approach towards a routine health information systems. For example, in the scaling up of applications like DHIS2, they can be very important to be to be trained in routine health information systems.
All right, thank you. Here's another question, Dr. Theo. It's from Dr. Nega. Thanks for the presentation. Do you encourage people to customize the syllabus to meet their needs?
Absolutely, absolutely. The course is really generic, but it was important to have a generic course so that everybody comes with the same kind of technical messages around RHIS, but at the same time, routine health information systems are very, very closely linked, as I said, to health services, and health services settings are very different in different continents, between Asia and Africa and Latin America and Europe and the United States. There are very big differences on how services are being delivered, and so we need to we wanted a generic course so that the people of the more regional settings can adapt the course. So yes, we want everybody to contextualize the course before teaching it. Like, for example, case studies and exercises need to be adapted to the socio-cultural environment in which the course is being taught. But also we need to adapt to the level of education of the audience and the role of the audience in the health system. Like I said, adapt the course towards care providers versus policymakers, towards lower educated staff in community posts versus hospitals, district hospitals, etc. So yes, contextualization is very important, still maintaining the generic technical standards that are proposed in this course.
Yes, thank you. The next one is from Dr. Eni. I am a lecturer of public health faculty in Indonesia. After the final version is established, can we just adopt it in our class? We have health information systems class for bachelor students.
I didn't catch the question, Cha. Can you say that again?
They're asking if they can adopt the final version once it's established. They have bachelor's class for bachelor students, Dr. Theo.
Absolutely. I think that's a more. It is also addressed in the contextualization guidelines, but indeed we would like to see that routine health information systems are also being taught in pre-service setting, in for example, schools for nurses and health technicians, medical faculties, etc. Because often when people like doctors or nurses come out, they have not had that exposure to what is an information system doing for them in order to improve service delivery to patients and clients. So bachelor degrees should be able to get some version of this course also, if it is a bachelor, for example, in medical sciences or in one of the laboratory technicians or nurses, like I said, midwives, etc. Yes, it should be taught at those levels, and again, that will definitely need even more contextualization, because it is assumed that many of the participants are already working in the health services, while these bachelors have not done that. So there needs probably to be a field component added where the students can visit health facilities, hospitals or districts to see how a health information system is working, to see how the computerized data management is being done, etc. So definitely we include bachelor level students as eligible for such a course if it is well contextualized.
Right. Next one is from Dr. Atike. He's asking, can you elaborate more about trainer for training workshops regarding RHIS? I would like to be one of the trainers from Pakistan chapter.
Yes, we hope to, like I said, we hope to organize at least a minimum of training of trainers workshops with WHO and measure evaluation, where various master trainers can be trained. For example, some plans are there to have. We are working with WAHO, with the West African Health Organization, and it is planned to organize most likely a course in Ghana at the University of Ghana for training of trainers. But similar initiatives can be set up in Asia with PHFI or with the Pacific WHO region, as well as the Southeast Asia region. That's why we are promoting the dissemination of the course via these networks like the EHIN Routine Health Information System Focus Group. Is a group where various countries can come together and share best practices, but they can also delegate from their country some master trainers that can be trained in a regional setting. We need to do further networking with EHIN and, for example, CIARO and WIPRO from WHO to see how we can in practice move on that, but it will happen next year for sure. So the first opportunity for Asia, like I said, is the EHIN Myanmar General Management Meeting, which will happen March 6th to 10th, I believe. So very soon.
Right, here is another question, Dr. Theo. I think it's for Dr. Himali, but maybe you can answer this one. The question is can the curriculum be translated to each country's needs, or is it for global issues only?
I think the question is around DHIS2.
I'm not that sure. The question is from Dr. Yuda. Maybe Dr. Yuda, can you clarify your question? Okay. We have another question from Dr. Ann. Dr. Ann was with us in Bali last year. The question is can the module be divided for specific people? Like for policymakers should be a different module and another one for health technicians? Something like that.
Yeah, I think I already handled that subject in previous questions. Yes, the only thing is that we need to get more experience on how we do that, because this course is just finalized, and contextualization. We did a first test to contextualize the materials for India for the pilot course. But we still have to learn how we do that in function of the audiences, like I said. So obviously contextualization for a course for policymakers is going to be different from contextualization for a course for health technicians. And we hope over the next years to refine the contextualization guidelines and maybe come up with proposed courses that are already adapted to policymakers, so that people don't have every time to start from scratch. But since we have not done it yet, the materials are not existing, so we hope to work with various institutions in the beginning, like PHFI or Mahadol University or various Asian institutes to develop such contextualized courses. Mm-hmm.
Right, thank you, Dr. Theo. Here is a message from Dr. Charmin from Dhaka. It is great to know that you have incorporated the feedbacks from the pilot test. We want to have the TOT for faculties of my Department of Health Informatics and Bangladesh University of Health Sciences. The question is, when and how can we have this TOT?
Yes, so my best greetings to Dr. Charmin. She was one of the participants in the pilot course. And I think one of our main advisors on this course is Tariq Azim, who works a lot with Bangladesh. And I know that he is already in contact with Professor Azad and others in the ministry to organize probably very soon a TOT for Bangladesh. So I think, Charmin, you shouldn't worry. It will happen hopefully next year.
All right, this one is from Dr. Ragavan. I own a private consulting services in HIS in Malaysia. Can a private trainer like me participate as trainer?
I think absolutely this is an interesting question because yes, in so many Asian countries, health service delivery is much more handled by the private sector than by the government sector. So we encourage absolutely private institutions to make sure that if they are, for example, serving an important number of health facilities, that they can have somebody trained in routine health information systems and set up further training of their staff in how to use information for decision making. We would be very interested in such initiatives. Naturally, they will have to happen via the Ministry of Health, so that there is some kind of regulatory environment around it. But there is no, I don't see. I think we need to encourage the participation of private sector providers and systems.
All right, here is a follow-up question from Dr. Ann. Is there any possibility to conduct the course in Indonesia?
Indonesia is also definitely a big priority country to start spreading this course with such a big population, and I am sure that this kind of plans will be further discussed at the AHIN meeting in Myanmar. So I'm sure that we will have some participants from Indonesia there that we could further discuss how to approach that in collaboration with AHIN and CIARO.
This question is from Dr. Ravindra from Nepal. Is it necessary to have a laboratory for some experiments for the RHIS course?
Well, you can call that a laboratory indeed. For the moment, it is a bit of a laboratory because the course is just developed and pilot tested. So yes, we will need to do further research on how the course can be adapted to various audiences. So yes, I like the name of laboratory labs. You know, we have some projects now where we do public health research, and we call them innovation labs. So yeah, why don't we create innovation labs for better teaching of routine health information systems? And let me make another little point here. It's not a little point, it's a big point. But my presentation was around the course that was developed, but let me tell you that capacity building is not only dependent upon one course that people get and be trained in. There needs to be a whole setup of follow-up under the form of reminder trainings or a supervisory system that is reinforcing the messages of the original course. So I think which that would be a topic of another presentation, but the capacity building goes way beyond just the initial course. But the initial course is important to have it put together. Thank you for introducing this this aspect of research in the further work on capacity building for strong routine health information systems.
All right, here's another question from Dr. O'Hagan. It reads, what was the average educational level of pilot participants?
Say that again? The educational level?
Yes, of pilot participants.
What was the educational level of the pilot test participants? Well, they were all pretty senior managers, national managers, but also district managers, but senior. And we wanted that on purpose because we wanted really feedback from experienced participants. So the participants themselves knew already a lot about the whole topic of routine health information systems. But there was in fact a mix, because some of the participants had less exposure but were still in senior management positions in their countries. I think the pilot audience was really a good audience that we picked very carefully so that we could get a maximum of feedback on the materials.
All right, I think that's the last question for tonight, Dr. Theo. For everyone who still has questions, you can email us at secretariat@ain.org and we will forward them to our speaker. Thank you for joining us tonight, especially Dr. Theo for sharing your time and expertise with us. To everyone, please look forward to the succeeding webinars we will be conducting on RHIS with Dr. Theo and measurement evaluation. Thank you, everyone.